Good afternoon, everyone. At the outset, I would like to thank Mindray and BLK Max, especially Dr. Anil Handu, for having me part of CubeSpire 2021. It's always a pleasure to be part of this event where you interact with everyone and look into different aspects of a very simple but my favorite assay or test, which is CBC. I know we would love to be had this meeting in a live meeting where we could meet and greet everyone. But in these times, the virtual session is we have, and we are lucky that we can at least have this academic interaction amongst all of us. The topic I'll be presenting today is about CBC flags and peripheral smear review criteria. So moving on, the concepts or the terminologies which I'll be discussing in today's talk are: what is flags? Flags are nothing but default rule settings by the companies, or they may be lab defined rules which tell us to, which highlight some variations or changes in the CBC result. What is the delta check? Basically, we'll discuss about how it is a comparison of different CBC runs on the same patient. We'll discuss about critical alert values, and we'll discuss a little bit about peripheral smear slide review criteria. So essentially, it will be a discussion on how one can use company settings or your lab defined rules, which are called as flags. Add to that the delta check and critical alert values, which then help us to define and set up our peripheral smear slide review criteria. As I said, flagging messages or flags is a sophisticated system. Basically, you could call it a type of artificial intelligence. This is based on quantitative or qualitative abnormalities. The role of flags mainly is to improve the the effective use of lab time, the technician and the doctor's time, and improve the efficiency of reporting in a laboratory. Manual microscopy still remains the gold standard and will always remain very, very important to cross-check the flags which are given by the any CBC analyzer. So let's understand what a flag means when a particular instrument gives any flag, whether it gives the CBC result as a positive or negative. For that, we need to understand the sample to a result journey. And I am going to talk about this journey in the current day scenario. So when a sample is run on the CBC analyzer, typically a technologist will look at the CBC analyzer, manually inspect all the data, and look for presence or absence of flags. Now, invariably, you will have either the slide review criteria or your flag review criteria either on a piece of paper stuck next to the machine, or there will be some flag rules given within the machine or your LIS system. Now, typically on the machine, if flags are present, and we will show how the machine will mark that sample as positive, and based on those criteria, it will tell the lab to make a peripheral smear based on the rule settings by the lab. However, if the flags are absent, okay, there is something called as validation settings in most analyzers, whereby the technical staff will validate that CBC result and will send the result through the output setting of the analyzer into the lab information system. From the lab information system, there are typically two levels of check depending upon the laboratory rules. One is the the technician checking the sample on the lab software and then provisionally authenticating it for the final authentication by the pathologist and the release of report. Now, this is a typical system where I would say sample to result journey and where the role of flag comes. There is another important thing to be aware of, which is called as auto verification. Now, this is the machine auto inspects for flags. If the flags are absent, the delta check is negative. There is an auto validation setting, which is then put out onto the auto output setting of the CBC system to the LIS. Now, in this auto output system, the results are then put into the LIS, and there is a system called as auto validation in your LIS also. So we will not be discussing the auto validation, auto verification in this talk, which is beyond the scope. However, I suppose there are a couple of other talks which will be focusing on this topic. What our focus today will be on the different types of flags. And when I say flags, they are nothing but the interpretative or IP messages, and they can be of two types: abnormal messages or suspect messages. Now, this is a name for a particular brand of analyzer which I am using in my lab currently, but the names or the type of messages may be different In different analyzers, the name of the flags may be different, the asterisk or the star mark or an exclamation mark may have different meanings in different analyzers. The idea would be to focus on the conceptual part of the flags rather than the actual wordings of the flag. Now, what do I mean by abnormal flag? The machine feels clearly normal or abnormal based on the criteria that you have given. For example, it is neutropenia or neutrophilia. There is no doubt in it. If you give a value of more than 2000 as less than 2000 as neutropenia, if it is less than 2000, the machine will give a flag which is clearly abnormal. Whereas a suspect message or a suspect flag means maybe query abnormal lymphocyte, query a blast, which means it wants you to review the smear and look for that. Now, based on the presence of an abnormal or a suspect message, the machine can give a judgment whether this result is positive for a flag or negative for a flag. If it's negative, as I said, there is nothing to be done, and you can go ahead and move to your lab-based rules. If there is no delta check, no lab-based rules are being, there is no lab-based rule flags, go ahead and you may not even want to see a slide. However, if the flags are present, the machine will give a positive judgment. Now, this positive judgment can be further divided into three different types. Is this abnormality based on certain differentiation value? For example, is it based on a neutrophilia? Is it based on a basophilia? Is it based on a monocytosis or a differential count? Morphology, for example, query blast, query atypical lymphocyte, that's based on the morphology, or a count, the number of counts. So it depends on whether it's a differentiation feature, a morphology feature, or just purely on the count basis. It will try and divide those flags to give you a judgment. And we'll see this as we go along. As we know, the flags can be in the WBCs, RBCs, and platelet. And as I said, in each, the WBC flag will be abnormal messages or suspect messages in the system. So let's go on to what are the different kinds of WBC messages one can have. So in the abnormal, clear-cut abnormal flags in the WBCs, one can either have a WBC abnormal scattergrams, and the rest are pretty simple. You can have a neutropenia or a neutrophilia. Similarly, lymphopenia or a lymphocytosis, eosinophilia. You may have presence for NRBCs IG. Now, the criteria for defining this are either defined by the company, and in some analyzers, the lab may have the flexibility to adapt or change these factors to the lab's requirement. For example, in the IG, the company criteria may be 2%, 3%, or 0.5%. For example, what we use for an IG flag is more than 1%. Similarly, for NRBC, you may use 2%, which is the default criteria of the company, or you may use less or more. Same way for defining a leukocytosis flag. If you want to keep it as anything more than 10,000, because for a routine lab, anything more than 10,000 needs to be reviewed, you can use that. But in a hospital setting with a lot of ICU sample, you don't want to see every smear or every infection of 14,000. You may want to keep the flag at a default setting of 18,000. So this is something which you can change. Based on the value you have given, the machine will flag it as leukocytosis or leukopenia. Now, similarly, in WBC, you may have suspect flags. As I mentioned, this may be based on abnormal lymph or blast, or query left shift is present based on the scattergram. The machine recognizes that there might be a few band forms or left shift or IG. It will give you and ask you to review your smear. Now, this is an example where the patient was on chemotherapy and was given growth factor therapy post chemo. Typically, post growth factor therapy, you see immature myeloid cells in the slide, and a flag which was raised here was immature grams and left shift. So if you see, there was a value given here for the immature grams to 19%. We reviewed the smear, and there were around 16% left shifted cells in this, which typically matches. This is just an example of how a flag for left shift or IG is given in a particular sample. Typically, it's based on this machine analyzer on the scattergram properties, where you have more events in this area where there will be a left shift given. So going on to RBC flags, within the RBC also there are abnormal messages and suspect messages flag. In the RBC messages flag, in the abnormal, the clear cut, as you know, there might be a dimorphic population. Typically, we see that post-transfusion or post-hematinic therapy, there may be flag for reticulocytosis, which is based on the retic count, absolute or percentage. For anastocytosis, the flag is based, for example, on the RDW CV or SD. For example, in our lab, we have changed the setting to more than 15. So we don't want the analyzer to flag anything which is even mild cytosis. Similarly, for micro and macro, we have put age-related reference range. And for example, in adult males and females, we have put an MCV less than 76 as being micro, and an MCV more than 95 being as macro. So many analyzers provide you to even put age-related reference ranges to adjust these things. Similarly, you can have your values adjusted for hemoglobin and erythrocytosis. Now, within the suspect messages group in the RBC, you can have RBC agglutination, suspect flag, which could be based on the scattergram on the MCHC value. As we know, in say a cold agglutinin disease, your MCHC will go above 40. Then there's a very useful flag which I find in practice, turbidity hemoglobin interference. Whenever you have a hemoglobin hematocrit mismatch, this often also affects as an error if the CBC sample has been kept for a long time and the RBCs have all collected together, the plasmas are collected together, and the technician forgets to mix the sample before running. You could aspirate only the RBCs and have a hemoglobin hematocrit mismatch. Similarly, in a very basic AI form, one could devise a flag for iron deficiency. There are some default settings by the companies for iron deficiency and hemoglobin defect or thalassemia conditions. One can put your own criteria, and I'll show you a couple of them. Also, you have flags for fragments, you have flags for infected RBCs, and again, we'll discuss these as we go along. In platelets, also we have abnormal flags and suspect flags. In abnormal, there will be typically thrombocytopenia and thrombocytosis. As said, in an oncology setup, the lab may define it as less than 50, less than 1 lakh, less than 60. In a routine run-of-the-mill CBC lab, you might want to keep it anything less than 150, or you may want to keep the criteria as anything less than 160, depending upon how you practice in your lab. So keep in mind, you can use the same flag as your slide review criteria, or you can keep one flag as a criteria for marking or telling you that this is beyond reference range, and then you can use a lab defined rule for making a slide review. So you could have a combination of flags, and we'll discuss that as we go along. We'll also see how, whenever the machine gives a platelet abnormal scattergram flag, how it is very important to go back and look at the scatter to assess whether the platelet measured by the machine is correct or not. And I'll give you a couple of clues how one can do that. So let's look at this machine flag. So here the platelet count is 1,39,000, and the machine gave it as platelet abnormal distribution. Now, two things are very clear to us. Once you look at this graph, the peak is going up, but the peak has not come down. So that means the analyzer does not know where to put this second green line or the cutoff, whether to put it here, here, here. And even if you ask, 5 doctors, 5 pathologists, 5 technicians, they will give you different places. That means this platelet count is not reliable. Based on this, what we did is we made a peripheral smear. Now, the peripheral smear is showing only 1 to 2 platelets. That means the count looked somewhere between 10 to 20,000. So we had this flag. Machine is giving a count of 1,39,000. This is a very odd scenario, but interesting to learn from. We ran the optical platelet count. It came to 10,000. Now this was very surprising. We had the opportunity. We ran it. This was matching with the smear. So what we did is we spun this sample. Unfortunately, this sample had a lot of hemolysis and degeneration. So there might be WBC fragments, RBC fragments, which are all interfering with our count. We called for a fresh sample. Even by the impedance, it gave a count of 11,000. So the importance is, rarely you may have these artifacts causing disturbances. But what this case has to highlight is, look at your scattergram. If it is abnormal, definitely try and see whether, is this correct, not correct, based on what your peripheral smear findings are. Now, let's go on to what is we called as judgment based on the flag. So we saw different types of flag, WBC, RBC platelets. We saw abnormal flags and suspect flags, basically quantitative and qualitative flags is what I would like to divide it into. And based, if flags are present, like in this particular case, the machine has given flags like microcytosis, erythrocytosis, because MCV is really low at 63, the RBC count is 6.79. The judgment of the CBC sample for a pathologist review is positive. Please evaluate this case. In this example, there are no flags given by the analyzer, and the judgment of the CBC machine for the technician and pathologist is negative. No need to review this case, is what the analyzer is telling you based on its own judgment. As I said, these judgment criteria to label neutropenia or neutrophilia are current day analyzers give the option to the laboratory to modify this criteria as per your clinical requirements. So whether it is RBC, platelet or WBC or the MCV or the hemoglobin levels, you can modify this judgment criteria. When do you want your machine to give you a positive or a negative judgment, and at what value do you want it to judge? So this is what the machine allows you to modify. So most of your abnormal flags or quantitative flags, which are based on values, as I said, the default setting of the machine was at 60,000, but in our lab, where we see both run-of-the-mill routine health checkup samples as well as infective patients, we want to evaluate every case where a platelet is below 1,50,000. So we say, judge the sample. If the platelet is less than 1,50,000, give us a positive judgment so that we know that we need to analyze or verify the CBC, and if required, evaluate the peripheral smear. So same way, those were the judgment flags. Those were the abnormal flags where a judgment is raised. And then you have suspect flags. In the particular model of analyzer we use, they are also called as Q flags. So this is the list of all the different Q flags, and there are in our analyzer a total of 10 different Q flags or suspect flags, which are blast, left shift, query, abnormal lympho, atypical lympho, blast, again infected RBC flags, and then the RBC ones or platelet clumps, which I discussed. Now I'll discuss one of them out of clinical interest. So this particular flag, what I want to directly focus was the IRBC flag in this analyzer. This was an 8-year-old case of nephrotic syndrome, also had an infection, 16,000 count. But because there was an IRBC flag on the analyzer, we looked for malaria on the smear. If you see the WBC count of 16,000, we would not have really looked for it. The clinician had not asked for a MP. He was not suspecting malaria, but the patient actually had both the Acol forms and Schizons. Rare case, we picked up a mixed infection. Now this is whether the mixed infection is not because the analyzer picked. This was just a review. We confirmed that on a rapid malaria test having both bands, and the clear-cut PRBC flag was, the value of the flag was more than 300. So basically, these are algorithms which are set by the companies. Generally, these algorithms given by the companies cannot be changed. So compared to your quantitative flags, where the number value of your neutrophilia, neutropenia can be changed, the algorithm for how the machine detects PRBC or NRBC in your particular model generally cannot be changed. Having said that, we will discuss a little bit about the cutoffs. Now, you can then change the cutoff. For example, the default cutoff in this machine for all Q flags is 100. Now, you can increase or decrease the sensitivity or specificity of your Q flag based on your requirements, though it is not recommended by most companies, but I'll show you where we had done a study before we changed the cutoff for one of our IRBC flags. So I'm not going to the details of the study. We wanted to evaluate the role of the PRBC flagging or the IRBC flagging for Vivax compared to the microscopic method. We evaluated these cases. We made a truth table. We got a sensitivity of 84%, a specificity of 99%. So we are wondering, why is the sensitivity only 84%? Can we improve it? So for improving it, we said, okay, there were 11 negative cases where the flag was not given by the analyzer. So when we analyzed those 11 cases, what we realized, that 9 out of these 11 cases had a Q flag value between 20 to 90. So it was below 20, there are a lot of false positives. So, it will alter the specificity and, make it worse. You don't want to oversee smears. In our practice, we have now kept the flag value at 40. The idea being, now when my staff analyzes the flag, even if there is a Q flag value of more than 40, the slide is reviewed for infected RBCs. So you don't mind, seeing an extra slide or doing an extra rapid malaria test, even in an unsuspected patient, because you are not going to give someone malaria positive just because your analyzer is given positive. So this is an example where we improved our sensitivity of evaluation and detection by reducing the threshold of that algorithm, and we made it at 40 is what we currently use in our lab. The next, going beyond the default flag settings, as I said, we have shown you now 2 settings. One is your abnormal or quantitative settings. Then we discussed about the Q flags or qualitative settings. And the third, typically lab-based settings, are the critical alerts. Now, what we have tried to do is we have incorporated the critical alerts into our flags or lab-based rules. As we know, you may have a WBC flag of more than 18,000. That becomes a critically important limit. For example, a hemoglobin less than 7 or 6 based on your lab criteria, because that sometimes becomes a transfusion requirement. You want to alert your clinician. Platelet which is less than 30,000 becomes a critical alert. So you want it to be highlighted even with a clearer message not only a slide needs to be reviewed, this is urgent, this needs to be verbally informed to the patient/clinician so that an action might be taken accordingly. So this is also important how you can put in these settings into your analyzer, middleware or LIS. Now let's discuss the delta check, and what this particular analyzer helps us with is gives us an action alert. Now action alert in this analyzer is based on cumulative data, which is nothing but evaluating the delta check. So we will discuss, for this example it gave an action alert. Okay, let us see the cumulative data. So in this machine screen, and different analyzers will have different screen, you can see the main settings which have all. Here there is a setting or a tab for the cumulative result. When you go to the cumulative result, in this particular case, you see the hemoglobin on 18th of April was 8.4, whereas on 16th of May it is 11. The analyzer recognized the ID number, it was same. It matched the difference and said that there is marked variation in the hemoglobin. So based on the same, it gives you an action alert. Please evaluate the data. Now it is important to get this from your analyzer. The analyzer should recognize that the patient is the same. However, if you use accession numbers, for example, where the sample IDs are different even for the same patient, you may not be able to do this in your analyzer. You may, however, be able to do this in your middleware or LIS better in most practical scenarios, because most labs use an accession ID or a barcode ID, which is different even if it is the same patient. However, if you have incorporated the patient's unique ID or a permanent ID into the system, into your CBC analyzer, then you can use the power of your CBC analyzer cumulative data action alert. Now, for example, here there was no action alert. If you see, the hemoglobin is pretty stable based on the criteria you have entered it into the machine did not give an action alert after doing a delta check. However, in this example, you see this is action alert marked over here. Here, there was a huge difference between the hemoglobin, 9.2 to 11.9, and we have kept in our lab a difference of 1 gram. The platelets, we have kept a difference of say 10%. So here it recognized a significant difference. And it said, when you click on this action tab, another tab opens up. It says significant change in hemoglobin, check the sample. Similarly for platelet. So this way one can use a delta check or an action alert or a delta check on your middleware or a delta check on your LIS to highlight to the lab that between the previous run and this run, there's a difference. Now, is it clinically different? You may go back to the history and you may realize, okay, either the patient was given hematinics, might be an improvement, or was, treated, now it has improved, which is a good sign. But it at least gives you an action alert that there is a gross difference. This becomes very critical in ICU samples where patients are improving or deteriorating. It becomes significant to identify errors. Errors, for example, typically pre-analytical errors where there is a, IV line collection, there is a sudden fall in hemoglobin, morning, evening sample showed a sudden change. So before you release the result, you already alerted that there is a delta check alert or an action alert present. Now one may ask, what are the criteria for delta check? ICSH guidelines are given. It's a very useful tool. You may define it as per lab-based criteria. You can modify it, but a very good reference is to follow what the ICSH does. I will not go into the details for want of time. Now, coming to the main thing, which will be the peripheral smear review criteria. Now, based on your clinical requirement in your lab, you will utilize all your settings which we just showed you in this talk. You will use the flags, which are the abnormal and suspect flags. You will use your critical alert values and your delta check to define the rules of peripheral smear review criteria in your laboratory. This article will give you a very, very good detailed analysis of how flags are used. They have given each and every flag, what are the different values one can use, what are the secondary analyzers which you can use, the number of days, whether the slide review criteria, whether you need to rerun it, whether you need to verify it. You can go into detail of this article, and see what to do, when this follow-up comes. So as I said, a requirement of a routine lab just doing routine samples in CBCs will be different from, say, a hospital, from a corporate lab or an oncology hospital like Tata Hospital. A Tata Hospital will have all oncology patients will have blast and suspect flag left, right, center, whereas it may not be as critical for them, but it will be very critical if you get the same blast or a thrombocytopenia flag in a routine basic health checkup kind of a system. So hence you need to make your own criteria. Now, how do you make your own criteria and how you evaluate? So for that also ICSH has given guidelines. What And I'm going to show you a study which we did, at my previous place of work at Hinduja Hospital. We had got this as, NC or a non-conformance as part of our NABL audit. And we were told, though you have your slide review criteria, have you validated them? So to validate, we wanted to define first, what are the criteria for a positive smear? Because what are we going to do? We are going to evaluate, is my machine flagging correctly? And is that matching? If I had unbiasedly seen my smear, would I want to see the smear or not? Are there any abnormalities in the smear which should have been marked up by the CBC machine? So what are those abnormalities? These are the abnormalities given by ICSH, which says RBC morphology of say microhypo more than moderate levels, platelets, if there are too many giant platelets are reduced, presence of clumps, presence of toxic granulations, and then abnormal cell types like blast, obviously metamyelose or left shift, NRBC is more than one, plasma cells more than one. These are the kind of things if you want see in your smear, you would want your CBC analyzer to flag. So we had some default criteria for WBC and RBCs. RBCs more, for example, hemoglobin more than 18, RBC more than 6.5, which were put into the analyzer. And we said if these values or these flags come, we will review our smear. And based on the ICSH criteria and our lab defined criteria, we evaluated 318 samples. So unbiasedly, the slides without seeing the CBC were seen by 2 pathologists independently, and the CBC review rules were compared, and we created a truth table. Now the most important aspect in the truth table is the false negatives. The false negatives are the cases where the machine has not flagged, you have not seen the smear, and the smear has gone, the sample report has gone without your review. As per ICSH or ICSH, the recommended level for the false negative is 5%. In our study, we got it as 1.6%. Now, one may say the slide review rate was very high at 58%. So what's the use? We'd rather see all the slides. But the challenge is at that time, our majority samples were coming from the oncology ward, where thrombocytopenia is present in almost significant amount of 50% and above samples. And our lab refined criteria was platelet count less than 150, we need to see a smear. We were doing a mixed analysis of both health checkup as well as oncology patients. So in a pure oncology patient criteria, we may have kept a slide review criteria maybe as 1 lakh, and the slide review rate would have gone down. So this is just to show you an example how one can put your rules. Now to summarize, you can use the flags, you can use judgment rules, you can use the suspect flag rules, and you can define your own slide review criteria. And here in this analyzer, this is what I use in my lab currently. We have what is called as comment rules. So what I realized over the years, we train our technicians and we tell them and we give them all the criteria. Imagine this whole talk has listed maybe 30, 40, 50 criteria. It is impossible for them to remember. We will say, okay, we'll give them an A4 page printout and put 4 printouts in front of the analyzers. But at the end of the day, they have to analyze 200 CBCs. Practically, they are not going to, go to every CBC and look at the printout next to them and review them. And even the smartest of technicians can miss out small things. So the idea is, can we train them on the job? Can we train them on the move? So currently in my lab, I don't have any printouts. What we have done is, we are training them to identify the flags. We have trained them to look at the positive alerts. We have trained them to look at the action alerts. And we have trained them to see in their mind, what is it, the reason the machine is judging. But we also help them because we have written review slide for high WBC count. So they know that the machine flagged the WBC for 20,000. So instead of just simply writing leukocytosis, which the machine already writes, this is our lab defined rules. Okay, we are telling them the machine is flagging for atypical lympho, and this is why we are reviewing the slide. So this is the actual flag which comes in my analyzer. So we have given an RBC count of more than 7 million. This is a lab customized rule. MCHC more than 36, review slide for a high MCHC. So this way we have put different index, and we'll discuss, say for this the BTT Sehgal index now in the next examples. And again, if there's a flag, platelet flag, I have put in a flag to say, please review the platelet histogram. Now at this level, the platelet histogram gets reviewed by a senior supervisor. The printout or a photograph of the same comes to me before I review the slide also. So let's show you a couple of case studies and examples. Now this was a health checkup sample from a 24-year-old male. You see the hemoglobin is 11.2, the WBC count was 11,000, hemoglobin looked 12.7 with the normal platelet. But if you see, there are two things. There's a positive judgment based on a flag given that there is microcytosis. And can you see this cloud kind of a mark? which tells my staff that there is a lab defined slide review rule to be alerted. Please click on this tab to see more. When they clicked on this tab to see more, they said, review the slide for low MCV, MCV is 65. Review slide for low MCH, so they go back, yes, the MCH appears 22. And it said Sehgal index positive, which is one of the THAL indices for screening which you have put. So there is no need to remember for them, no need for a calculator or a phone to be held and put in the indices and calculate. The machine itself has flagged. What they then go on to do is they put this into our LIS. They put in the comment that based on the indices, this is suspected THAL trait and an HPLC is required at the technician level itself. So by the time the CBC or the slide comes to us, we already know it's been flagged. So this Sehgal index is based on a publication. This is the reference article where we used the formula of MCV square by RBC less than 972. Now this is purely to be used, in our practice as a criteria in a lab. This is not for community screening. This is useful only to evaluate, screening THAL traits with more sensitivity and specificity. One could argue that sensitivity of various other indices are great. You could use any indice. This, out of my own experience and practice, is what we are using in our analyzer. So this is an example of, the beta THAL flag. We have put in actually the formula. So it's again a sort of an AI system where we can use different formulas. Similarly, I've added something for hematocrit hemoglobin mismatch. As I said earlier, in severe dehydration, dengue patients, or a false alarm or agglutination, these kind of flags get highlighted, and this is very useful for us in a lab. So the idea is to inspire the young viewers out there is you can define your own algorithms, you can create formulas. The currently analyzers, middleware, and LIS give you the opportunity to put your formulas into the system. So not only will you get good results, you will train your technologist to get more efficient data out of your CBC analyzer. So again, an example, there was no action alert, no flag, there was no cloud here, a negative you could verify, and without seeing the rules, without seeing the slide, you could validate the case. Again here, though based on the company rules, the machine gave it as negative, but there was a cloud alert or an action alert based on our lab criteria. The staff clicked on it and it said review slide for IG. The IG was 1%, which is a criteria which we wanted to see the slide on, and a slide was reviewed. Now this is a case where the machine gave a flag. This is a similar case where you have microcytosis, erythrocytosis. There's a flag alert, and the flag alert is based on the THAL trait index being positive and a low MCV and MCH. So similar features seen in both ways by your lab defined rules as well as by the company defined rules, which alerted the staff to make a flag. Now this is another case where you have low platelets, you have borderline low WBC count, and a hemoglobin is 10.3. There were machine based flags, hence the machine gave it as a positive judgment. There is a cloud here. Again, when you click on the tab, it says review the slide for a blast, review the slide for low platelet count. So in case the staff has missed out on seeing the the graph, because there are a number of flags here, they may not have scrolled down, they may not gone to see the graph. At least they have another place to alert them that okay, this cloud and a positive judgment has come. At least see the error rules and comments, make a slide, make a printout, show the graph to the pathologist, and then take it forward. So to summarize, a thorough knowledge of analyzer based flags and settings is extremely useful for a lab. I would always recommend that the CBC analyzer's user manual and the application team are a very good resource, and you must utilize it efficiently to understand your own analyzer. The peripheral smear review criteria are very important. They can be customized as per the lab requirements and should be validated against established guidelines like I showed. The future is auto verification and auto validation of CBC results. This is important. This requires a rigorous validation before implementation. However, it can really increase the time and cost efficiency of CBC reporting. With that, I would end and be happy to take any questions. Thank you so much.